our talks. We have 3 speakers today, and I think the aim of the session was really to learn from various experiences during the pandemic of both the challenges of mounting a robust evidence response and developing guidelines for practitioners of public health during the pandemic. So to give you some background on myself, my name is Jeremy Grimshaw. I'm a senior scientist at the Ottawa Hospital Research Institute and a professor in the University of Ottawa. And I'm just going to share my screen and we'll get going. So hopefully you can see my screen now. So my job today is to tell you about the experiences of the COVID-19 Evidence Network to Support Decision Making, also known as COVID-END. And delighted to present this on behalf of my colleagues, and in particular, John Labis, who you'll hear has been my co-conspirator in during all of these efforts. So one of the things, or the reason COVID-END started was that we recognized very early on in the pandemic that there was an explosion of interest in and demand for evidence synthesis. And that was a real positive. This was a time when decision makers, whether they are policymakers or clinicians or citizens, were desperately trying to find information about COVID as the evidence evolved. And we saw a great response from the evidence synthesis community. There was a substantial increase in evidence synthesis and supporting activities. Now that sounded great, but there were a number of challenges. One is a lot of the people who were getting involved in evidence synthesis were relatively inexperienced and hadn't got a lot of experience of doing evidence syntheses before the pandemic. Most of the early work focused on rapid reviews, largely on clinical and public health topics, and there were variable quality and variable transparency of the reviews. There was a huge amount of duplication of effort, and the discoverability and longevity of rapid reviews was uncertain. At that time, there were relatively few living systematic reviews or guidelines, and there were particular sort of challenges in terms of the evidence synthesis capacity and conduct issues in low middle countries. So one of our colleagues who was working in Africa described having to buy data on people's cell phones when their country went into lockdown, so they could actually sort of continue with the work they've done. To give you some idea about the duplication of effort, the National Coordinating Centre for Methods and Tools in Canada undertook a rapid review of maternal and fetal risk of COVID exposure in May 2020. They planned to do an update of that in August 2020. And by the time they did it, they identified more than 50 reviews on the same topic had been published in the interval. So, and these reviews will be of variable quality, and sort of most of them will be rapidly out of date, and a lot of them may be quite hard to find. So there's a huge duplication of effort, which was actually really problematic because it created a noise to signal problem. There's so much noise in the system, it's often hard to find high quality evidence syntheses that should be used to inform decision making. And the other issue is there was a silence problem. Most of the reviews focused on clinical interventions and relatively little on public health or health system or the economic and social implications of COVID. And so we had this remarkable, huge range of activities on one side, but really it was not, we thought, meeting the needs of key decision makers globally. And if you want to have a nice summary of that, there's a nice paper in Science by Jeffrey Brainard in October 2020. So this was a backdrop that basically gave us the impetus to create COVID-END. And we formed COVID-END in April 2020 as a time-limited network of international evidence synthesis, recommendation, and intermediary organizations that came together in response to the exogenous shock of the pandemic. And we wanted to promote collaboration and cooperation among the evidence community and reduce inappropriate duplication effort. I've been involved in the evidence synthesis community globally for over 30 years. And the way this came together was quite remarkable. So at the time, John Lewis and I had some funding from the Ontario Ministry of Health, which was to provide evidence support around a health system transformation that they were initiating. But when the pandemic struck, the health transformation was put on hold. And so we discussed with the Ontario Ministry of Health whether initially we could use those resources to help develop syntheses and evidence products that were relevant to people in our province. So that was on the 31st of March, and they were very sympathetic to that. On the 1st of April, we had an internal meeting, John and his team and myself, and we basically wondered whether other colleagues around the world recognize what we saw as these very substantive problems in the evidence synthesis response during the pandemic. So we decided to hold a couple of exploratory meetings and just get people around the table and see, one, did they share these concerns, and two, did they think we could come together to do something about it. So we sent the invitations out on the 4th of April, which I think was probably a Saturday. And we had our first meeting on the 6th of April, and about 20 groups turned up. Second exploratory meeting on the 9th of April. And by the 16th, what was clear from those meetings is there was this shared recognition of a problem, but really a shared commitment to the idea that we could work together better if we and help each other if we joined forces. So on the 16th of April, COVID-19 was formed, the name was agreed, and we established a number of working groups. And I've never seen something come together within such a short period of time. So the original funding for COVID-19 for the first 9 months, we really were doing this with very little funding whatsoever. We had some of the money from the government of Ontario, as I said, and we also, the National Institute of Health Research in the UK contacted us because they wanted to support us, and also individual donors in the US contacted us. It's the first time that I actually had funders coming to me and saying, you know, we think this is important and we'd like to fund this. Fortunately, sort of during the second phase, we basically managed to get additional funding from the Canadian Institute of Health Services Research. But the initial impetus was we just had to do something and start running if we wanted to try and address this problem, and then we could work out or try and work out sort of how we could fund this after that. And here we currently have 55 organizations from around the world, and it truly is global. And here are not all of them, but many of the logos. And so you can see that we have some very large evidence synthesis organizations like Cochrane, Campbell, the Collaboration for Environmental and Evidence. We have colleagues in Africa, the African Center for Evidence, ACRES, Makerere University. We have colleagues from the guideline world. So we have GIN, we have NICE, Joanna Briggs Institute, a very broad range of partners who are coming together because they recognize this real problem. And during probably the first 3 or 4 months, we actually met twice a week. And then we went down to weekly meetings, and we sort of basically, slowly as things have become a bit more coordinated, reduce the frequency of the meetings. And the underlying rationale of COVID-19 was that we wanted to move from the initial high noise to signal evidence phase, which you could characterize by having rapid reviews of variable quality that were quickly out of date with huge duplication of effort, and a find and pick your own mentality, to high signal to noise evidence phase, where we'd have curated high quality living evidence syntheses and evidence support initiatives. So we distinguished a sprint phase, which is that initial slightly chaotic phase, and then the marathon phase, as we've all learned that the pandemic wasn't going away anywhere quickly. So in terms of the sprint phase, here are just some of the examples of things that we did. We had about 8 what we called early wins. One of the things that we did very early on is create resources to support researchers who were considering or conducting an evidence synthesis. And what we tried to do there is, first of all, get people to make sure there wasn't a review that was already being done in this topic. And then sort of basically is a bit like an evidence synthesis 101 crash course of this is how you should, this is what you need to do if you want to try and do a high quality systematic review. And the WHO recognized that we had managed to convene a very large group of the evidence syntheses around the world. And so they asked us to join its secretariat function and for the WHO Evidence Collaborative for COVID-19. And these were groups that were working with WHO on the evidence response. And basically what we wanted to do is try and make sure, again, we were encouraging collaboration, cooperation, awareness activities of the EC19 network, as well as COVID-End. And we created things like principles and resources to support evidence packaging for decision makers. But as we moved into the marathon phase, we basically argued the world would be best serviced by a global stock of high quality, accessible and actionable living systematic reviews addressing the most important healthcare, public health, health system, economic and social issues faced by decision makers. The reason I bolded health system, economic and social issues is that in the first phase of the pandemic, these were largely ignored in the evidence synthesis response, but clearly are really important. We are still, I think, increasingly sort of dealing with the economic and social consequences of COVID-19. That we needed to develop evidence synthesis capacity to undertake high priority syntheses efficiently where they were needed. So as well as having a stock of living reviews, there's always going to be issues that pop up in different jurisdictions, and we needed to make sure that there was capacity to develop high quality reviews in those areas. And in particular, one of the key challenges here was to sort of try and make sure that colleagues in resource poor settings had the capability and capacity and resources to do these syntheses. We also recognized that we needed local evidence support initiatives to enable decision makers to find, interpret, and contextualize the best evidence to meet their needs. So this is where examples of evidence intermediaries like the EVIPNet network are really crucial to help those decision makers who were really sort of trying to deal with a very rapidly evolving field, just to find evidence and make use of it. And then two final things: a global evidence infrastructure that builds on existing organizations to deliver coordination and prioritization and ensure efficient conduct and sharing of high quality evidence syntheses, and secure funding to support the entire evidence ecosystem. We wanted to try and avoid people reinventing the wheel, but rather joining forces with groups like Cochrane or Campbell or Acres in Africa, in Makerere, so that they were, wherever possible, building from and working with these global leaders in the field. So a couple of examples of things that we've done during the marathon phase. We created an inventory of evidence syntheses trying to improve the signal to noise ratio. So we identified by about May 2021, there were already over 13,000 syntheses relevant to pandemic, but only 36 of those were living evidence syntheses. We deduplicated them, then we tried to identify reviews that were particularly relevant to decision makers, and we assessed those using AMSTAR. We looked at how up to date they were, and also whether they were using grade-like processes to assess the trustworthiness and certainty of the body of evidence that they found. And from that 13,000 syntheses, we identified 652 that we thought were relevant to and of high quality and up-to-datedness for decision makers to consider during their first, if they were sort of trying to find evidence in an area. And so we created an inventory which had a structure that allowed people to very quickly find out in whether there are high quality syntheses relevant to their particular question. So that was an example of improving the signal to noise ratio. The other thing we did, and this was particularly more of our local work in Canada, is we developed methods for ultra rapid and living evidence syntheses. And some of these were contextualized, so were particularly sort of relevant to the individual jurisdiction that they were, where they're done. Others were more broader global evidence supports. So what happened here is we developed a range of methods which would, where we could provide summaries of the available evidence in 4 hours, if things were absolutely urgent. More often it was in sort of 5 to 10 days, and occasionally we were able to provide people that we needed living evidence syntheses. We had created a demand and supply coordination in Canada, so we had a central entry point for federal and provincial decision makers to feed their questions in. And we also did a monthly horizon scanning both globally and within Canada, so we were trying to understand what were the issues coming down the pipeline. So again, by about May, June in 2021, we had already had 150 products produced over that period of time. And some of these examples included living evidence profiles, which are these very rapid syntheses on long-term crisis management, vaccine rollout, and the lessons learned. And also a number of living evidence syntheses. So we have currently maintaining 3 living evidence syntheses on vaccine effectiveness given variants of concern. The one looking at sort of adults has been ongoing since May 2021, and has been updated over 20 times. We have a review looking at the waning of immunity, which initially started off as a one-off review, but then our decision makers in the Public Health Agency of Canada recognized that this was something that really was rapidly evolving and we needed to keep on track of that. And then more recently, the census on variants of concern and vaccine effectiveness for children came on board. And these are being done by 3 different groups, 1 in Colombia, 2 in Canada, and they're working together to share resources. And at the moment, we're on a monthly update cycle. And every month we meet with the Public Health Agency of Canada to basically present the updating living evidence syntheses. So the last thing is, very early on in the pandemic, we recognized that there had been both sort of whilst there had been many sort of examples of suboptimal practice in the evidence synthesis community, there was a lot of really positive innovation. The sort of ultra rapid reviews, for example, would be one of those areas. The greater emphasis on living evidence synthesis as a pandemic was another. And so as we start to come out of the pandemic, I'm not sure whether we're there yet, but we felt it was really important that we should try and learn from all the experiences during the pandemic and start to reimagine what the future sort of evidence support systems could be. How could we actually build a much stronger evidence support system so that we could address the needs of diverse stakeholders who might be citizens, practitioners, policymakers, across all sectors, i.e. not just health. So the arguments about needing a strong evidence support system in health are equally applicable to agriculture, to climate change, to education. So really thinking about what have we learned and how to help us think through about how we can build a better evidence system in the future. And so we convened something called the Global Commission on Evidence to Address Societal Challenges. And we brought together 25 commissions from diverse backgrounds to identify the characteristics of evidence support systems and made 24 recommendations about how to get there. The report was released in January this year, and it's available in all the WHO essential languages and Portuguese. So this is an example where we can learn a huge amount from our experience in the last 2.5 years to think about how we can do things better in normal times across all sectors. So whoever you are around the world, whether you're a citizen, a practitioner, or a policymaker, we have adequate evidence support for you. And my colleague John Lavis, I think, is presenting later today at this conference, or maybe tomorrow. So if you want to learn more about it, you should attend his session. So just to finish off now, here's basically a few ways of contacting us through our website or Twitter or email for both COVID-19 and the Evidence Commission. If you want to know more about our work, then please go there. And we're also very interested in the Evidence Commission, that if there are groups around the world who are interested in the work that we've done and want to use it to generate discussions and activities in their sectors or their jurisdictions, we'd love to sort of hear from you. And yeah, we will try and help as much as we can with you to take that forward. So that's what I had to say. So just wanted to say thank you very much. And I will pass this back.
Thank you,
Dr. Rawaf is here. Wonderful to see you.
Hello, Jeremy. Thank you very much. I do apologize to you, to Janet and Atle, that I have really technical problem which never encountered before, because we tried the system yesterday and it was working and it's in my diary, but it didn't work today. It is one of these things. So good evening, good morning, good afternoon, wherever you are. And great stuff. I managed to catch part of it. And thank you very much, especially to the link. Can we have the link back so people take a photo of it? I know the slide will be circulated, but just some people may be eager to take a snapshot of it and contact you and colleagues for more information. The reason I say that, because I will make a comment on that after Atle and Janet, is that many policymakers are still confused. And I stop with this statement, but I will allude to it later on. Next, I think let us have the three of you, and then we will have some discussion toward the end. I think the next is really very, again, fantastic and interesting talk about Norway experiences during the COVID pandemic, with particular emphasis on the role of randomized trial. I know many questions raised about some of the randomized trials conducted in different parts of the world, especially in high-income countries, but we look forward to listen to Atle. Atle, we are in your hand.
Thank you very much, Salman. You hear me okay?
Yes, I can hear you, but
okay,
you don't.
Great.
Very good, thank you.
So yes, thank you for inviting me to this. So I'm Atle Fretheim, and I am the head of a newly formed center. It's existed for 1 year. It's called the Center for Epidemic Interventions Research, located at the Norwegian Institute of Public Health. And my background is health services research, research synthesis, impact evaluation. So basically, research close to policy making, or hoping to be of support to those who make decisions. That's the goal of most of the things that I've done. Yes, I was invited to speak about our experiences from Norway during the COVID pandemic, and specifically on what basically is the lack of randomized trials when we talk about infection control measures. So I'm going to talk about what we have experienced in terms of trying to learn more, to get more and better evidence about the effects of the non-pharmaceutical interventions, or the also called public health and social measures. These interventions have many names, but what I'm basically talking about are things like face masks, mandates, school closures, ventilation measures, etc., etc. So all those kinds of infection control measures that are not pharmaceuticals or vaccines, basically. There's been a substantial, astonishing variation across, if you look across countries in the world, and also close to each other countries, in how they've moved forward in terms of choosing which infection control measures to implement in their countries. And I assume that the lack of convincing evidence for these various measures is one likely explanation for the variation. I think I also personally believe that the weak evidence in general for most of these types of interventions is also fueling the polarization in this field that you see, especially in some countries where there are extreme oppositions against different sides of the field, when there are discussions about the effectiveness of face masks, school closures, etc., etc. I would claim that the fact of the matter is that there is huge uncertainty, and there should be much more humbleness across all sides, which in itself will probably provoke everyone on both sides. But the middle way is probably a humble approach in trying to generate more and better evidence. Here's one example. This is let's see now, I'm just, so this is just a snapshot that I found on the web, illustrating the huge variation in the policies around face masks at a certain point in August 2020, where we see, doesn't really matter what the different colors represent, but you can see that there's a huge variation in terms of whether face masks are mandated or whether it's just recommended, or all those different things. Here's another example. I'll show you several of these pictures of school closures, which I find particularly interesting. So here is a snapshot from at the very start of the pandemic, at least from the European perspective, mid-March 2020. I'm from Norway. That's the green thing in the middle up north there, the long green gray one. Sorry. I suppose most of you know, but I shouldn't assume that everyone does. But it's the long slim thing there is Norway, the gray one alone. So that color tells us that Norway actually implemented school closures very early. There were very few countries that had school closures as early as us. But again, you see there's huge variation across the world. If we fast forward 2 months, we've actually opened our schools again already. So we were early closers and very early openers. At this time, it was a really interesting combination of countries that had open schools in the world. It was Norway, it was Iceland, it was Belarus, it was Turkmenistan, and Papua New Guinea. Those were the countries with open schools at this time. And this is not, of course, I did strategically choose this date because it illustrates my point, but just to show that this is not an exceptional picture, let's fast forward another month and you'll see that there's still huge variation and very, very few countries at this time still that have open schools. I'm not making a moral judgment or a scientific judgment as to whether this was a good thing or not, because I don't know, and neither do you. So that's part of the problem. But it illustrates that there was, and still partly is, huge variation as to how the different governments in the world have managed this pandemic. This is one of the extreme examples. Uganda, schools were closed there continuously from March 2020 till January this year, so almost 2 years. And final photo of international situation concerning school closures. This is an interesting map that illustrates how long schools have been closed in total during the pandemic up until recently. So you can see that some countries have had almost a year or more than that, and some countries have only had a few weeks of school closures. So huge variation that cannot be explained, I think, by differences in incidents or other things. This is about other things. I don't know, values, interpretation of evidence. I don't know. Norway has a very, very strong tradition in the idea of children's right to go to school. It has a very, very strong, I would say, almost an emotional impact on the debate. And that probably explains to some extent why we reopened our schools so quickly, I believe, but I don't know. So the point I tried to make with these illustrations was that the evidence base is poor, and a consequence of that is that we have huge variation. This is how, I don't know if you've been interested in health services research, for instance, it's the same thing. All through the 80s and 90s, health services researchers demonstrated how much variation there was, and the reason in terms of how hospitals chose to organize things or what kinds of interventions they offered to their patients. And the reason was obviously, to a large extent, that there was a weak evidence for many of these interventions. This field of research is totally dominated, I would say, by observational approaches. So meaning you use to take the data that you have, that you can collect, and you try to interpret it and to see if you can tease out some indication of an effect. So you would compare different states in the USA with different approaches to face mask mandates. You would compare different countries with different approaches to school closures, etc., etc. But there are lots of problems, as I suppose most of you know, with this type of approach when you try to assess whether an intervention has had an effect. There are co-interventions. So when the Swedes in Sweden, our neighboring country, they did not close their children's schools. They did close their for the older teenagers, but they did not close the schools for the younger children, while we did. But comparing is impossible because there were so many other differences between our two countries. Co-interventions, different changes in disease prevalence over time for reasons that we can understand or not understand. There has been geographical variation even inside countries, of course, because the pandemic has been unpredictable, and suddenly there is an increase in prevalent incidence some places, not in others. Sometimes we can understand it, sometimes we cannot. Often interventions have changed after they've been implemented. Always, I would say, outside the control of researchers. So it's very difficult to interpret differences when interventions have been changed over time. And another very practical problem for researchers is that testing policies have often changed over time. And I would say most of the impact evaluation research that has been done in this field has been based on statistics of recorded positive tests. And then when testing policies change over time, or they change in different locations and not at the same speed, it becomes very difficult to use this data for anything to try to understand whether there are effects, whether differences that you observe are due to interventions or completely other things. So usually in most fields, or at least in most medical fields, the idea that randomized trials is the optimal approach for studying the effects of interventions, if they're possible to implement. That is usually, there's a wide consensus around that, because randomized trials is an effective tool to reduce these risks of biases that I've listed up just now. But unfortunately, in this field, in non-pharmaceutical infection control measures, there have been very few randomized trials before the pandemic and during the pandemic. Here is a Cochrane review from more than 10 years ago on physical interventions to interrupt or reduce the spread of respiratory viruses. And they did not find a single randomized trial at that time. 10 years later, they found one that was conducted in Japan around 10 years ago. So there's been very, very little done in this field. If you look at a couple of systematic reviews that have been, or reviews, well, yeah, they're both systematic reviews, that have been conducted during the pandemic, focusing on studies that have been conducted during the COVID-19 pandemic, there's also very little, although there is some improvement. So these guys found one, what they called interventional study, which was a randomized trial. And that was all they found when they looked at public health measures. They had their definition of that. The point here is there were very few. These guys found a little bit more. This is a scoping review, but it's a bit wider in their inclusion criteria. I believe they also included hospital studies, for example. But anyway, they found 12 completed randomized trials in this area, which is nothing when you compare to the number of trials that are being done in the drug vaccine field. Here is a scorecard from the BESI collaboration that hasn't been updated recently. It was updated some months ago, and it illustrates. So the first top boxes, actually, you can look at the boxes to the right. They are the number of trials that have reported results, and there's almost 1,000 drug trials on COVID-19 that have been reported, and they have found 17 what they call BESI trials, which is basically non-pharmaceutical interventions. So the point is, again, very few trials, grotesque difference between the number of trials done on drug interventions compared to non-drug interventions. And it's a big question. Why? Because logically, these non-pharmaceutical interventions have a huge impact on everybody's life. So we really need to know how effective they are, and especially and also try to quantify their negative effects. These are huge, dramatic political decisions that are being made in countries as to which types of interventions to use or to implement. And as of now, it's largely done based on logic and assumptions and very little on solid evidence. So why then? Why do we see so few trials? And I don't know, but I have some experience, and I've talked to people, participated in some meetings, and these are what I believe are the main barriers or the causes why we don't see many trials. And happy to hear from the participants when we discuss later if they have other explanations than these. So I think there are cultural barriers. Historically, I think the public health field and people working in the health field have not shown much interest for randomized trials. There's been this idea in many groups that randomized trials in this area are impossible. And that is a point, not that they are impossible, but they are difficult to carry out. So that's a reason, but there's also been a general lack of interest that's my impression. Then there are legal barriers. For example, if you want to test or run a trial of an intervention where you need to intervene on groups of people, for example, different communities. So you would like to randomize, for example, the municipalities in Norway, like we've wanted to, then you have a problem with getting consent from everyone who's being experimented on. And individual consent requirements that are part of the ethical review process are a big barrier, at least in Norway, and I also believe in other places. But that varies. Then there are political barriers that many of you may have encountered. The idea that you let a lottery decide who gets and who does not get a certain intervention is intuitively difficult for many in the public and among policymakers. So that is a real issue also in our experience. Then there are methodological barriers, and a specific one is the need for huge trials. After all, the effects of these interventions are not usually enormous, so you need a big sample size to be able to demonstrate an effect, if there is one. And then there are practical barriers. If you need to do these trials in collaboration with policymakers, and often in our experience, there's no time to wait to plan a trial because there's an eagerness to roll out an intervention now. So even waiting 2 days, you can't get the political support for that. That's our experiences several times. And then, of course, financing might also be a problem, but I put that intentionally last because I think many of these trials could actually be done with very little funding. Here's one example, a practical example. This was the first suggestion we had in Norway. You may recall that we closed our schools very early, and we realized that the schools would have to reopen someday. So we started very early to propose a randomized trial of reopening as a means of trying to assess the effects of closing schools. So having a situation where we randomize schools to remain closed or to reopen. And then we would measure, well, whatever we thought was important, things like incidence among the children or in the communities, psychological measures among the children, and learning outcomes, which could also be measured to some extent. We had a methodological barrier. When we did our sample size calculation, we saw that we needed basically all schools that are found in the country, which is obviously a challenge. We also had a political barrier. This is our Minister of Health, who was positive to the trial and understood the point, but in the end said that from a knowledge perspective, a trial is a very good idea. He got the point, absolutely. But I don't think the public is ready for having a lottery decide if their schools open now. I think he was absolutely right, to be frank. And then we had the legal barrier that I mentioned. We had proposed that the mayor or the municipal physician could consent to trial participation on behalf of the whole municipality. but that is simply not possible within the legal framework in Norway. You need consent from each individual, and obviously that's impossible to get consent from everyone in all schools, and especially not everyone in all municipalities, basically saying everyone who lives in the country. So that's a hopeless situation. This is, well, in one sense, an attempt to brag, to show you how much we've done, but it's not actually, it's failed attempts. It's a lot of things that we've tried to do, but we've failed. But it illustrates, that we've tried at least, and how difficult it's been. So all these attempts at randomized trials of these types of interventions failed for a mix of the reasons that I've already mentioned. Much is ethical, legal problems linked to consent, and others are more political or public resistance to the idea of running a randomized trial, or fear among the politicians that we could, leading them to not being able to wait long enough for us to prepare a trial, which could often be very quick, but still not quick enough, those sorts of things. I have to say, though, it's not all dark from our side. We've had a few successes, but I wouldn't call these, these are not huge breakthrough trials, but we have at least been able to conduct some randomized trials of these types of interventions. We have been able to randomize distribution of face masks to see if that increased the use of face masks outside grocery stores. We have been able to randomize municipalities in Norway so that the people, immigrants living in half of the municipalities, received campaigns on social media to try to encourage testing. This was at a time when testing was a problem, lack of testing among certain groups. We've also run a trial of having family doctors call up unvaccinated patients. So we randomize the patients to get a telephone call or not. And we've done a trial with a few thousand people in Norway who agreed to be randomized to wear or not wear glasses or sunglasses when they were out among people, to see if that reduced the spread of COVID. So, I mean, these are not Nobel Prize stuff at all, but at least there are, probably we're the only ones who have done 4 randomized trials in this area, although we shouldn't exaggerate the importance of these trials at all. This is just to prove that I'm telling the truth. These are the front page of 2 of the only ones that we've published formally so far, these trials. I want to mention towards the trend, to the end, that there are initiatives. The problem of lack of good, robust knowledge about the effects of these types of interventions. Here they're called public health and social measures, which is the term that is, I think, increasingly used and WHO has proposed. So there is a secretariat that has been established at WHO that has been tasked with the specific activity to try to move this field ahead. So they're working on that in collaboration with us. A multi-year initiative to measure the effectiveness and social health and economic impact of public health and social measures during health emergency, aiming to strengthen the global evidence base on public health and social measures. So they're trying to address this whole issue. I mentioned this, the BESI collaboration, which has also been more sort of like an advocacy group, I should say. Jeremy Grimshaw and myself have been active in that group, focusing on the need for more research in this area. And finally, this is actually a bragging slide. In Norway, the Ministry of Health, due to, I would say, indirect lobbying, we never asked for them to do this, but we pointed out repeatedly the need to run trials, and we were never able to do that, or almost never, but they saw the problem and they decided actually in the state budget to establish a center specifically targeted with working or tasked with working on these issues to try to get more effectiveness studies in this area. And that's the center that I'm heading. We're eager to collaborate. We're eager to understand why not more people in the world are trying to do this, to run trials in this area, or if there are people out there trying, but also failing like us. We could have a group and cry together, or we could find solutions and collaborate. So very happy to be contacted by people who are interested in making an effort in this field. Thank you.
Thank you very much, Atle. Thank you. It's really, really interesting. I mean, there is a big ethical question which we need to discuss later in this session after Janet. Should we wait during a public health shock or a health system shock to the evidence? I mean, this is a question we need to keep in our mind. As somebody all his life as a public health practitioner, I have a lot of question mark about this. All right, from the World Health Summit, from the big and the great on earth, we are actually pleased to invite Janet. Janet, although she's at WHO, but currently she's in Berlin. Janet, the floor to you.
Thank you so much. Can you hear me okay?
Yeah, fantastic. Thank you. How is the summit, Janet?
It's a very good summit. So it's my privilege to be here with you and to discuss the topic of living guidelines, which is what I was asked to discuss, but I think the previous speaker has opened up many important topics to discuss as well. But in the regards of living guidelines for WHO, our role, has been to develop norms and standards. And so for emerging infectious diseases, which is what I work on, then the idea of what are the clinical guidelines and therapeutic guidelines emerging infectious diseases, and COVID-19 was the perfect example because the world needed fast guidelines that were made in a transparent way, of which you guys understand very well. But what was our problem? The problem at that time in 2020 was that we did not know what was a treatment for SARS-CoV-2 infection. We didn't know. It's different than other diseases. All we knew was that there was an emerging infectious disease that needed treatment, and we knew that there were some supportive care interventions such as oxygen therapy, blah, blah, blah. And we also knew that there was a research agenda happening that we needed to stay on top of. And so at WHO, when we had to decide what were the interventions that we were going to recommend for COVID-19 in 2000, right after the pandemic, it was like, we need to set up a system for evidence synthesis and evaluation, all the way to recommendations. And then I'm going to talk about the rest immediately. So we decided we were not going to compromise anything. We needed evidence generation, which is what many colleagues did. And then we also needed evidence synthesis to translate into recommendations at the same time. And I think that's like one of the key points here is like, were we able to do that in a timely fashion? So what did we do? At the WHO side, and for my colleagues who are on here from WHO, we established a steering committee like we always do. And you guys, many of you guys have been a part of our steering committees for other diseases. But this was not like something we could convene every 3 months or it had to convene as we needed it. And I think that's where the challenge was, because it was so urgent to do something right away. So we had an ad hoc committee that prioritized therapeutics treatments for COVID-19 guideline development. Then we needed someone who was going to do the synthesis of the evidence, who was going to search the evidence base every day. And you know how complicated that is. This is what you guys do all the time. To look at the evidence generation, there was hundreds of studies in order to see what was coming out, what was being studied. Can we evaluate and synthesize and grade all of this? This is a problem. So WHO, we made a decision to go with one LNMA, Living Network Meta-Analysis team for McMaster's, and say, you will be independent. We will commission you to look for evidence for us on a daily basis. That team today, I don't know, they must have 50 or 100 people working for them just to look at evidence generation, screen, and start to synthesize evidence. Then we had a GDG. Who is a GDG? These are clinical experts in all specialties, from primary care to infectious disease, to virology, to ICU. I mean, COVID has spanned the clinical spectrum of diseases. Really, it has spanned it. So it's not that an ICU doc is the most experienced or the primary care. We had to bring all of them together. And WHO, like you know, brings experts together to be unbiased, unconflicted, in order to write recommendations for the organization. So we decided to go with a GDG process that was open, that was always non-conflicted, that can surge, you know, if we needed more people that were in primary care or more people that were in ICU, we can do that. If we needed more people who understood virology, we could do that. But that everyone was cleared of conflicts of interest and would accept to our confidentiality agreements. And methods. Oh, we needed methods. We all know how important it is to have methodological support for our guidelines. So what WHO needed then was to commission an independent group that was able to provide us methodological support to ensure that we could synthesize and translate that evidence into guidelines using normal approaches such as GRADE that everyone knows, using values and preferences statements that we all agree, and trying to consolidate evidence into summary of findings tables. Writing recommendations. Then we proceeded there. We had guideline groups that convened almost every 2 weeks at the beginning of the pandemic. Virtual. When had we done virtual guideline development before? But we had to find a way. We had to train all the experts on GRADE, have a good interactive way to discuss with them to ensure that we have consensus in our guidelines, a standardized approach. And finally, publication. Publication where we can publish these WHO guidelines developed by our independent guideline development group, monitored and facilitated by our independent methodologists that looked at the data that many of you colleagues were synthesizing for us. And then we did that. And then we did that with some electronic publication platforms, such as the MAGIC platform, which also served as one of our major methodological support groups, the BMJ, which served as one of the ways that we disseminate our guidelines, as well as the WHO website. So as I finish, you know, guidelines are really important, that they be evidence-based, transparent, and trustworthy. But at the same time, we can't stop there. It's whether or not the patient received the treatment that we're recommending. And so the work on adaptation and use of guidelines remains a big priority. The work on access and regulatory issues around making these treatments that have been proven to be life-saving available to patients. The work on supply and demand, that patients receive that in their clinical care pathways, the training of health workers, the webinars that we put up, and everything else. So with that, I think we have made great strides in the COVID-19 pandemic, and I look forward to working with everyone in the near future.
Thank you very much indeed. Janet, you raised many points for discussion. whether the public health response from WHO was timely enough or not. This is, of course, debatable. And whether the living guidelines were ahead of the curve or just behind. I'll leave it to the discussion. And we have Janet, Atle, and Jeremy. Let us have some discussion. I have one question on the Q&A here, or two questions. Was there any psychological, I think this is for Atle, was there any psychological intervention earlier in COVID pandemic? Atle, Janet, Jeremy, anyone of you want to answer it?
I can start.
Yeah.
Okay, do you want to go?
Jeremy, carry on.
No, go you, Jeremy, because I'm not sure.
I think there were. I mean, many of the public health and social measures that are used to manage the pandemic and hopefully reduce spread are based on behavior change, and so are very much sort of basically driven by a lot of sort of practice and theory. I think what we found is in different jurisdictions there's different levels of interest or willingness to engage with behavioral science experts. So in Ireland, for example, very early on, there was a behavioral science working group that was established to inform the Department of Health there. Whereas in my own country, Canada, really we lagged behind very significantly. And in my own province, probably quite late in the pandemic, we established a behavioral science table. So I think there was implicitly what the public health measures are psychological and behavioral, but I think we probably varied in terms of the extent to which we took expert or advice from experts in the area, and we certainly missed opportunities for us to think about manipulations to see whether we could do things that would increase the amount of social distancing or masking, etc. So it was part and parcel of all the country's response, but often I don't think we made best use of available evidence and expertise, and we failed to generate new evidence. Over.
Okay, thank you. Atle?
Yeah, no, the same thing. And I think in our country, in Norway, we had not a lot of specific focus on that. We did routine or regular measurements through surveys of how people seem to think about or adhere to or accept the different types of interventions that were being, to what degree did they actually wash their hands at the time when that was in fashion? To what extent did they wear masks, distance, all those things, and what did they think about it? But we did not, as far as I can recall, have a psychological approach in the policy, in the actual interventions. I mean, you could say that some of them were psychological, but that was not sort of the intention, I would say. So we could probably have done much more on that, especially when it comes to adherence to the different types of interventions that we really tried to push. So like social distancing, etc., and how we could have moved ahead of that. And we are actually, since I'm in the bragging mode, we're setting up a lab to try to test different ways of presenting information, for example, or messages, to see how people respond differently to those. It's much used in typical psychological research.
Janet? Janet, are you still with us?
Yeah, I'm with you.
Yeah.
So I think I agree with the colleagues. I think we have to try to apply good methods to different fields. I spent a lot of time working on treatments and on randomized controlled trials for COVID-19 or for other infectious diseases, and that's fine because it's a little bit understood how we would approach that data. But I think we have to apply the same methods and the same grade to evidence synthesis for other types of data that may not be coming out of controlled trials, for transmission of new pathogens, for different interventions, for public health interventions. And I think with all the smart minds we have now working on evidence synthesis and evidence analysis, and understand that trials all can't be randomized controlled trials for interventions, then there's a big opportunity for us to set a stage where we can put methods on how to assess, evaluate, and synthesize evidence from these different types of questions that we will encounter and are encountering. Thank you.
I think most probably we will give some of the answer later on. To be very honest with you, when we said, that I say from my experience as an academic and practitioner, as well as clinician, served on one of the regional WHO technical advisory committee on COVID and served 3 member states COVID committees, that at the beginning of the pandemic, to be very honest with you, we didn't have any evidence that we can use to deal with this new virus and a new dynamic. When we describe it in a paper that this is a new virus and a new dynamic, which is not fully understood, some people were laughing at that time, you know, and even when we projected that we may go up to 9 waves, you know, I remember the people reviewed my paper in March 2020, they were very, very critical in terms of which model you used in your projection to be 9 waves. But anyway, we proved to be right. The confusion also that there was panic, not only among politicians, public health policymakers, there was panic among our clinicians. You know, I'm most probably one of them. That we faced with this crisis, and we felt more or less that we are not in control for the first time in our professional life. That we have patients admitted to hospital, a very large number. We don't have sufficient capacity. We don't have sufficient protective clothing. We don't have sufficient equipment, ventilator, etc. We don't know which drug is working, which drug is not working. So it's almost, I don't want to describe it as paralysis, but in one of the paper I mentioned, there was really what I described, the clinical confusion. And here that clinicians and public health and policymakers started really to make decisions on their own based on no evidence. Giving that drug, giving this hydroxychloroquine. When you look at the picture now and dissect it very well, the whole map of evidence, even waiting for a very simple evidence or even reviewing an old evidence, all disappear. And in addition to that, we received tremendous confusion from WHO in the initial stages. To wear mask or not to wear masks. There was very explicit message from WHO, no, don't wear mask, you know, and that contradicts some of the national policies. And that's why some of the states in rich countries, you know, they went ahead without guidance from WHO, without collaborative work. We've seen how some of the European countries were actually inventing policies and guidelines as they go. And we've seen how United States and the confusion within CDC and the administration, Deborah now documented that in her book. The administration were saying something, the professionals saying something else. And last but not least, I mean, Janet, you talk about every 2 weeks producing guidelines. I mean, some of the well-developed countries, they were talking about guidelines produced every hour, you know, because the evidence is changing from experience, basically. These are practical evidence, not scientific evidence, not based on trial or based on anything which you can describe it as scientific. They were clinical evidence and saying, look, this one is work, this one doesn't work. We need this. Hospitals were not ready. We couldn't really zoning our hospitals. Primary care, I remember we drafted in May 2020 a guideline for primary care with colleagues at WHO, which is never published, until much, much later. So primary care was almost paralyzed in many countries, closed in some countries, and continued with high cost in terms of infection and life in others, So I just want to describe this because how can we learn? And there are a few questions which I'll go to it. How can we learn? And this is really the three of you. How can we learn from that chaotic experience, at least in 2020? Janet, ladies first.
Thank you. I think you raised many important things. I think we have to learn. There's no option. There's no other alternative that we have to learn. You raised many important issues, and I don't think I want to repeat all the things, but I think developing systems where evidence, there's different parts of the evidence ecosystem that you've described. One is evidence generation, right? So do we have the capacity to, and the right research protocols to test the interventions you're describing, in infection prevention and control, in transmission, which were some of the biggest gaps we had at the beginning of the pandemic for COVID-19. Do we have those in place? The second is, do we have systems in place for evidence synthesis and assessment? I worked a lot on that for COVID-19 and in the therapeutic realm, where we could just set up living systematic reviews so we can look at randomized controlled trials on treatments in order to make the best recommendations based on that. And
we lost Janet. I cannot hear Janet.
So,
Karian, sorry, we lost you a bit, Janet.
Oh, sorry.
Maybe the last sentence, maybe the last two sentences.
No, I'm just saying, so I think there's so much work we have to do. The evidence generation, synthesis, implementation science is not just amongst one group. I mean, this is not just amongst us, it's amongst the health system group, it's amongst the R&D and innovation groups. And as long as we can do collaborative work, then we can do this. I think we can do this. We've made tremendous progress with COVID-19. We were forced to. And so we must build on that.
Janet, you say that, but do you think member states or countries are willing to learn? I know this is a political question. This is a political question.
I can't see why not. I'm a technical person. But I can't see why not. We have to advance to that level because pandemic preparedness and the new global health architecture has to integrate this.
Name one question that they are today investing in their public health workforce. Name one question, one country. So I will really carry the flag tomorrow in the middle of Geneva, celebrating that. Name one country for me.
Let's talk about right now. Let's talk about Uganda that's facing a new Ebola outbreak for Sudan virus. The Sudan Ebola virus. So there is a country that has been working on preparedness for a long time because they're so close to where we've had the most recent. And we've done developmental training in those countries and they're prepared, but we don't know the right antiviral. We don't have the monoclonal antibody. We don't have the vaccines for this strain of Ebola virus. Mm-hmm. But we can put into place trials, studies, standardized data collection, harmonize, all that. We can do it. We are doing that now with the Ministry of Health for Uganda. So it's possible. That's a small example because it's one disease in one country. Huge impact for the world, that we maintain and contain that. COVID was different, but I feel the premises of those standardized data harmonization, evaluation of interventions. We have to maintain with that type of approach over things.
Atle?
Yeah, I think there are lots. Yes, for sure, lots of things to learn. What I'm not very optimistic about, but I could very well be proven wrong, is our ability to learn from the data that we have in terms of trying to understand the effects of the public health measures that we have used during the pandemic. I think the situation is quite bad still. I think the chaotic situation you described both in the clinical field and the public health field, we didn't know what were the most effective approaches. The clinical field has moved ahead. They have done the trials, so there's much more evidence there now, also of course for the vaccines. But for public health, it's not a real big difference now in March 2020, which I think is scandal is maybe too strong, but it's very, very problematic.
Disappointing.
Yes, that's a good word. Thank you. That's the right balance. Disappointing. Yeah. But so of course, what we learned is that we should, to the extent practically, ethically, politically possible, try to set up trials as early on as practically, ethically, politically possible.
Yeah.
I think that's an important issue. I think it's a problem. You asked whether we're willing to learn. I think the polarization, hopefully it will sort of die a little bit out over time, but the polarization, even in the academic fields, is, I believe, a problem in that it hinders research. There are strong pressure groups on all sides who are against research on the interventions that they're either convinced work or convinced that do not work. And I think so ethically not acceptable for opposite reasons. And that's, I believe, is a problem and illustrates the whole mess that we're in to some extent.
Yeah. Thank you. Jeremy?
I think we can do a lot better. And just thinking, not necessarily for this pandemic, but as we think about preparing for future infectious disease outbreaks, both seasonal outbreaks, intermittent outbreaks like Ebola, as well as potentially future pandemics. We have a limited number of transmission vectors. We have a relatively limited range of public health and social measures. Wouldn't it be wonderful to have a suite of living systematic reviews that were maintained of the effects of public health and social measures by transmission vector? Wouldn't it be great to do a series of living systematic reviews about promoting public health and social measures, so they've become just part of the global stock of what we have? What we can also do, I think, is we don't have to wait for a pandemic to do trials which will be helpful for generating knowledge in this area. We have seasonal flu, which is highly predictable.
Yeah.
So we could do things like trials of trying to get masks, wash hands, other things. Clearly, if you have another pandemic, the kind of panic you talked about, that may modify the effects of some of these things, but we can start to measure them and look at them. We know that there will be, unfortunately, another outbreak of Ebola somewhere in the next 3 to 5 years. What are the kind of questions around the public health and social measures do we need to do around that? We can also do things in terms of providing training for school children in terms of public health protections. So I think we can do a lot more. I think if we come out of this pandemic, I agree with that. I think we'll have learned very little. And if we come out of this pandemic and just put everything down and wait for the next pandemic, we'll have the same mess. If, on the other hand, we say, what do we have to do as a global society to start to give us the tools, which will mean we are better prepared the next time this happens, and at the same time we can deal with, or also help address seasonal or specific outbreaks, we could be in a much better space. So I think we have to start planning now, arguing for very strongly, this isn't going to cost a huge amount of money. A suite of living reviews would cover those things off and just maintain them. Let's give it a 15 to 20 year horizon. It's peanuts in the global scheme of things. And then let's plan using groups like Atle's, this idea about how can we generate trial data now, which will help us in future pandemics, will help us with other outbreaks, and generate robust evidence, somewhat outwith of the kind of the absolute urgency and panic situation that we were in March, April 2020. Over.
Well, thank you very much. I will tease these issues further later on. But one question I want to log, then I'll take questions from our participant. There are some interesting ones I can read. I believe, correct me if I'm wrong, I believe we lost the public. The public actually has now no confidence in the medical profession and public health and politician in dealing with shock like pandemic. The best example now, actually, Professor Azim Majid just sent a very interesting social media message showing that actually the public don't believe the message about vaccination, especially when the evidence just released a few weeks ago suggesting that drug companies didn't tell us that actually the messenger RNA vaccination or vaccines variety of it exist did not protect against the transmission. I want you to think about it while I'm taking a few of the questions here. Let me click. There's one question from Abu Mustafa. Do you think lifestyle, climate, type of food, race had made difference in health authority intervention with regard to COVID measures? So this is one question. Second question from Melanie Golob. Evidence is increasingly used in political decision. What can be done to increase the likelihood that population-wide RCTs will be accepted by decision maker? What lessons has been learned from RCT success versus failure? So let us take these two questions and we will go to others in a minute. Who want to volunteer? Atle, because there is the...
I'm happy to volunteer on the second one, if I may.
Carry on.
Yeah. So yeah, I think there is a potential. I think that my impression is that the politicians, but also the public at large, to some extent, has now seen close at hand the problem with not having good evidence for these various interventions, and they have suffered from these interventions, and most people have taken part in fierce debates about whether it makes sense to close all the pubs or not. So this is on the agenda. I think we're far from having everyone being engaged in debate about how to run a randomized trial, but I think we're much closer, and the idea that we need to work together as a country or a community to try to get this evidence and take part. My feeling is that we moved ahead. We were able to get quite far in some very large trials with large participation, potential participation, and we think we could have succeeded in terms of recruiting tens and thousands of people who would take part because they saw the need and the usefulness of doing it. So I think it's possible, and I've said in some other contexts that I think the high point of my career as a researcher trying to support policymaking was exactly the meeting that I briefly mentioned with our Minister of Health, where I explained why we wanted to run a randomized trial. And he so obviously understood why we needed to randomize. He said directly, if we close the schools first, if we open the schools first, where the incidence is lowest, which everybody will ask us to do, then we will ruin the trial, right? He said. And he was, so he got the point 100%. And that made me very optimistic.
I think but you're right. They may get the point, but whether they follow it or not, that's something else. Yeah. I mean, the example which I always remember and several times appeared on television talking about this, why the United Kingdom delayed the decision in terms of the lockdown. You know, despite the evidence from Imperial College through Neil Ferguson, which all of you know, based on fantastic calculation and the projections through very complex, sophisticated modeling processes, showing very clearly the number of deaths which will happen if we don't lock down now. You know, yet the decision took the government about 2 weeks. That 2 weeks delayed meant an extra of 100,000 dead. Who is responsible for those dead people? And why the public should really trust us in the future when they lost loved one, people finish with long COVID, some of them suffering since 2020 until today, you know, the cost to the health system for long COVID and the treatment of COVID patient, etc., etc. There's a huge areas which we need to explore. Janet, the first question.
Thank you. I think, you know, we have to move to try to do better in the future. You know, there was decisions made, there was assessments made. I think if we can further develop our approaches to evidence synthesis, and I'm going to go back to the focus of the conference of evidence generation and synthesis for these important, not just therapeutics, because that's what I've been mostly working on, but for the public health interventions, then yes, we would be able to make more timely recommendations in regards to public health interventions, in regards to treatment interventions, in regards to all these other infection prevention interventions. But we didn't have all that framework in place when the COVID-19 pandemic started. So we were, as others have described, you know, creating the, what's the expression? You know, building it as we moved. But I know now, of course, like, yes, we have to have better ways to understand transmission, better ways to understand interventions to reduce transmission, better ways to understand the public health interventions, both not just on the health side, but also on the multi-sectorial impact that we didn't have those evaluations available for us to make decisions at the time. Over.
We have a quite interesting question from Professor.
Could I make a comment?
Sorry, Jeremy. Carry on. So I apologize. Carry on. Sorry.
The 2 week delay was nothing to do with the evidence. It wasn't to do with the science.
Mm.
Yeah, so I don't think we should blame the science for the 2 week delay.
No, of course not.
This was a political judgment. The politicians were trying to balance multiple things and often would come from this from a sort of specific perspective. So I think we need to divorce science is one input into policy decisions. And we can't blame science if policy decisions are made that may have consequences that we as scientists would say could have been averted, as long as that is on, you know, as long as the science is robust and has been presented to those decision makers. It would be great to have much greater transparency so the citizens of countries could know what science was being seen by the politicians, so they might be able to start to make some independent views on that. But I think we need to be very careful. Having more perfect science would probably not have made any difference in my country, in the UK, in others, or in my province, not my country, around that. So I think we just need to be kind of quite clear about, you know, what our role is. I think when you talk about we lost the public, one of the reasons we lost the public, certainly in my jurisdiction, but I think in others, was that, again, there was very poor, inconsistent messaging from politicians and public health officials who report to politicians, which meant that that people were confused. They didn't know what was going on, what they should actually do. So I think we need to, you know, recognize there's a range of factors that influence decision making, and also the way in which decisions are communicated to our societies can have a major impact on whether societies trust governments and public health groups. And often, following the UK, the people, the citizens could see there were inconsistencies in the guidance, which made no sense whatsoever, which started to get them to question this. So I'll pause there, but I think we need to be quite cautious about not blaming the science. We can always do better, but it's actually a very complex field that we're then playing in.
But the politician, Jeremy, you say that, I say that. I'm sorry, I'm trying to be the devil advocate here in this session. But you say that. But as a matter of fact, the politician, time after time, said we are guided by science and scientists.
They may say that. They may say
exactly.
that, but then they
how
are interpreting it. Oh, come on. I mean, you know, Salman, I mean, I can say I am following the, something, but I don't necessarily do. And I may not take on the messages that, the scientists would wish that we did. If you look at what happened in the UK and the creation of Independent Sage, that was a response about trying to have a more direct channel to the public, because many of the people in Independent Sage were on the official Sage, but they felt that the evidence input didn't lead to policy outputs that were in the best interest of the public. So let's give the information to the public. Yeah,
I mean, we have a communication from colleagues, Dr. Fatina Tahan, saying very true, said, we lost the public. We as health worker physicians, we felt that patients no more fully trust their physicians like pre-pandemic time. I mean, this is from practicing physician tell us exactly what I said. And I experiencing it, other people experiencing in many countries. And I actually, in my capacity as a president of the International Association of Medical Colleges, I visit a lot of medical colleges around the world. I'm talking to, lay people, staff, etc. Even staff, they don't have any confidence anymore in themselves because they are a practicing physician and finding difficulties in sharing evidence with the public. Let us take another question, which is from Lubna. Lubna, Professor Al-Ansari raised interesting question in terms of how can we help the new generation to avoid this confusion. I'm not using what she is from memory. This confusion if another pandemic or major shock to the system will happen, whether at regional or global level. And will they be happy to look at what we are preparing for such eventualities? Janet? Are you confident that WHO will convince the new generation in the future? God forbid.
We have to build, everything's about, gaining knowledge and sharing information and increasing capacities and competencies. So I think we can do it. I think we have to do it together. It's all of us at the same time. It doesn't matter where country you're at. It's just understanding how evidence is generated, how to interpret that evidence, how to look at evidence synthesis. And, I think COVID has really sparked us to do that better. Not in all the sectors that we've discussed, but it has pushed us to look at evidence synthesis and evidence generation and recommendation writing in a more structured way. So I think we have to build on that, and I think we can do it. So I'm a positive person at the end of the day, and I'm privileged to be here with you guys. So I do think we can do it all together. Thank you.
Okay, I'm glad you are optimistic. I'm optimistic too. Atle?
Yeah, no, I agree. I think we talked about this a little bit already, that if we can do and make an effort now, like Jeremy actually sketched out in more detail, how we could plan for doing more research over the coming year to be better prepared, and also be better prepared, not just in terms of knowledge, but also in terms of being able to run studies when the next pandemic arrives. That will be a great, then we can look our children in the eyes and say that we've done this. I think that that'll be of value and be appreciated. One very, very brief comment. I don't feel, as you guys in the UK talk about, or where the comments are from, that we lost the public and that we lost the health personnel. That's not what I feel in Norway. And we've discussed this, and this is not my interpretation, but we have a belief, I think it's widely believed in Norway, that the reason we have maintained a reasonable high trust in government and public health authorities is that we've been open from day one about uncertainty. So there's not been an authoritarian approach in terms of do this because we know this works. It's more like, okay, we want you to, we implement this. We're not sure how effective it is, but we, being open about, being transparent about uncertainty has seemingly been useful in Norway. I'm not sure about this. Nobody can be, but it seems to be the case.
Can I ask the organizer, Lubna, what time should we finish? Because Jeremy wants to leave. At 11. All right. So at 11 Saudi time, at Geneva time, we have about 20 minutes, 25 minutes. All right. Jeremy,
I thought the scheduling was actually for 10:30, but I can stay.
Okay. Jeremy, I know it's a bit late. What time in Canada now?
No, it's early in Canada. It's 4:30.
Oh, 4:30. It's early. Anytime you want to leave, Jeremy, thank you very much for Libna written. We could finish at 10:30, but apparently people are enjoying it, so we can continue for a bit. If Libna give us a, she said it's very enjoyable. Thank you very much, Prof. Libna. We have some questions which I really like, and I kept it toward the end in terms of what should we do, where should we invest in the future. Thank you, Jeremy. Thank you very much indeed. One of these, Janet Atle, question: should we introduce, for example, infection control measure in the school curriculum, say secondary school curriculum? Janet?
Thanks. I think good infection prevention and control interventions should be introduced early on. And I also think that we have to improve the way we look at the evidence around infection prevention and control interventions. This has been a big, topic and that's not my specialty. So I will preface that, and my colleagues at WHO are working hard on this. But can we add more methodological framework, expertise to looking at this so that we can get faster answers to transmission, to the best IPC measures for different pathogens, especially emerging infection pathogens. That would be really helpful. So, and then what can go down to the good IPC measures, the good hand hygiene, wash, those interventions that we know prevent infectious diseases in general. Yeah, I think we can do that at all aspects of the community. Over.
I think, Janet, in addition to this, yes, we can introduce the curriculum is good practice, because infection control at home, from public health measure, most of the infection happen at home. At home is one of the riskiest places in terms of indoor pollution, kitchen infection, bedroom infested with a lot of things, and so on and so forth. But the big question, Janet, related to this, and I'll come to you in a minute, Atle, is that if you look at the early months, even the first and second year of the pandemic, and we did risk assessment in a few countries, we found majority of the infection, the vast majority of over 60% of the infection were happening in health establishment, mainly hospitals, and in some countries, of course, they have private clinics, majority of the doctor practicing from private offices happening there, because hospitals were poorly designed. Until today, most of our hospitals are poorly designed. They may not be able to cope with a big shock in the future unless, and I'm glad some countries already started redesigning their hospitals, that you can create zoning very easy, red, amber, etc. So it will be interesting to take the control of infection measures few steps ahead, looking at design, look at really our professional behavior and practices, look at the technology, how technology could be used to avoid that sort of contamination which is happening, etc. Atle?
Yeah, I'm not sure. I guess I agree. I mean, it sounds like a good idea to introduce this in the curriculum. I have been trying to put things into curriculums and they're full. That's a general problem. Getting things into school curriculums is nearly impossible because they're packed with stuff. So that's one issue. You need to make a very, very good case why it's important for children to learn this. And I wonder, but I may be biased by my own interests, but I wonder if it's more useful to teach health literacy or critical health literacy in the sense of, in a more broad sense, and also in the scientific sense, teaching the next generation. This touches upon something you asked me about earlier. Can we get the public to understand the value of doing research, and perhaps thereby having more people being interested and willing and contributing and taking part in research so that we can learn. And this, I think, is an important role of the schools, to teach the scientific basics of, trials, of course, or other types of research that we need to understand more of how we can mitigate infections or outbreaks or pandemics. I'm not so sure about, are there specific what interventions should we then teach in school? I mean, yes, the home is an important spreading arena, but I mean, are we talking opening windows? Are we talking washing hands? And are we really sure that these are important measures, important enough for us to spend time from the curriculum? So I know I'm just asking questions now, and I don't know the answers. Worth a discussion, but I'm not willing to just say, yes, great idea. I'm a little bit critical.
No, I think today at WHO and in Geneva, as I said earlier, at WHO meeting, we were discussing the issues of healthy living rather than just being healthy, and prolonging life through health. Most of these things, I agree with you. It's about good public health practice, being awareness of risks in life, and these risks are, as you know, endless, and we have evidence in terms of how can we prevent certain risk across life course, and these will be taught to the children early. They are not only about themselves, but also about younger kids. It's about taking care of the elderly, in the extended family, the support which they need to give, the environment in which they are live, the support to the community as a whole. It's really energized them, and it created a sense of belonging. And that is what I believe behind the question. Lubna is now teasing us with very interesting question. And she is saying, again from memory, I read it earlier, that a clinical trial did show that no evidence mask will prevent transmission. So why politicians make decision on observational studies rather than evidence? So that to you, Atle, you have the evidence, but they make another decision.
Yeah, I like provoking questions, as you might imagine. I think it's great. Well, first of all, you know, I am my bias is I hate to wear masks. I don't like masks, but I have a scientific approach, I believe, to the question, and I disagree. I don't think you can say that the RCTs. I guess there are like 2 in the COVID area and a handful of influenza trials of masks. And I don't think you can say that they show that that they don't work. You can say that there is perhaps lack of evidence that they do work, but as you know, lack of evidence is not evidence that it lacks an effect. So we still don't know. It's an open question. And the observational evidence, the expert opinions, and the logical approach leads many to believe that masks are effective. And the observational evidence. And I agree that the randomized trials indicate that the effect is at best not very big, but there is huge, those trials ended up with uncertainty. And one of the trials, the Bangladesh trial, actually showed an effect, although the numbers were small in the end and there wasn't a big difference. So yeah, but I think the policymakers listen to the experts. And if you ask most public health experts, they will say, from a spectrum that masks probably work a little to be completely convinced that they have a huge effect. And I would say that, you know, you can't say that with a certainty, but many people do, also among the professionals.
I think let us finish this meeting with a few questions. I think the question of vaccination, Atle and Janet, are dominant these days, not only in this lovely lively session. And thank you, all of you, and Libna, the organizer, for this opportunity. Question of which is anonymous question, one of our colleagues attending here. Do you think that the issues of COVID measures and vaccination might affect the response of people to vaccinate their children, especially with the misinformation being spread in the social media? What are the steps to gain the trust and the confidence of the public? Janet? You are muted. Or she's gone. Atle, you want to address it?
Okay. The stage is mine. I'm alone with you.
Yeah.
So yeah, no, I don't know. I think my main insight is from my own setting in Norway. My feeling, I haven't seen any data, but my impression is that we don't have this problem. I don't think that the trust in the vaccination program has been much weakened through the process. But it may have. We will see. It'll be interesting to follow how the uptake of vaccination in Norway. The uptake of vaccination is huge. Even for 3rd dose COVID, it's, I don't know, in the 80% range or something like that. I don't have the figures, so they might be a little bit wrong, but it's high. The trust in the recommendation from the government is really good still, and I believe that it is about being transparent. And being open about why we make, or I should say the government makes the decision that it does, what the evidence is, how the evidence is weak or strong, and the assessments that are made of downside and upsides. It'll be very interesting now to see. We're planning actually a trial now of the 4th dose, the 2nd booster, for the healthy middle-aged. They have not yet been recommended or not even given the option of taking the vaccine in Norway, because our experts are convinced that the effect is very small and they're not sure whether it's worth it. So we're now about hopefully, I'm not sure if we will be able to do this. There are many barriers, but we are planning to invite half the population, 500,000 people, middle-aged, healthy people, to be invited to take the vaccine, and the other half of the population will not get the invitation. And the most exciting thing is to see how that is, whether that is accepted in the population, that we actually make a lottery to see who gets to take the vaccine or not.
I think Norway is an interesting example. I think the Nordic region, generally speaking, there is a huge trust between government and the public, and the culture is different. I recall when we discussed the issues of Sweden and their approach to COVID, although they admitted later it may be a little bit wrong in the early stages, etc. But because of the culture in Sweden is totally different than the rest of the world, there is so much trust between the public and the people. And people listen to the government and the public. The people listen to the government, and the government trust the public in implementing things which, based on their knowledge, ability, what is given to them, etc. That's why they avoid instructing them. You know, it's different culture. In England, for example, we don't have that. You know, there is mistrust between the public and government, and this is not new. This is aggravated, for example, against the wish of the people in 2003, that the government actually intervened in illegal war in Iraq, totally against the wish of the public at that time, and proved to be the public is actually right. With the vaccine today, as you know, the people over the age of 70, they take the vaccine because they experience the protection. I think younger population, once you start to move toward the younger population, the curve dip a bit, you know. So the uptake of now we are in the fourth dose, and some people raising the question when that is going to end. Should we have a seasonal vaccine, which is, of course, with the mRNA is not possible because the impact or the protective element of mRNA is up to 6 months, between 4 to 6 months, which of course we knew about it before the vaccine was invented. That's the nature of mRNA. I think I covered most of the question. I simply check the panel, which is, there is nothing here. And toward the end, let me say, Atle, what a pleasure having this session with you and Jeremy and Janet, although both of us left us. I apologize for being late. This is not in my hand. I've tried very hard to link. I'm thankful colleagues who helped me from Riyadh. And thanks to Lubna, we are very, very grateful. It's very, very informative. Unfortunately, I couldn't attend the whole conference. I wish I can, but certainly I will join some of the part tomorrow. Thank you very much indeed. Thank you.
Thank you very much. Thank you.
Bye-bye. Bye-bye.